Welcome back to 12 Days in March. In this section, we'll be reviewing pulmonary fungal infections. This section is quite unique in that the diseases do not drive the content, rather, the organisms do. To be sure, we'll review the diseases, but questions pertaining to this topic are totally about the organisms. Signs and symptoms of the diseases are simply clues about the organism. You'll see what I mean as we tackle this topic. I need to open this section with a confession. When I started the process of sorting out what to include, this topic wasn't on the short list. I thought the details you were being asked to memorize were picayune and ridiculous until I saw the light. And what does that mean? There are essentially 8 organisms to be familiar with compared to 1 million bacteria and viruses. They fit into neat little categories, and there really are many distinguishing features and categories to help you sort them out. Whereas I was stubborn about the morphology, with the slightest effort, they are pretty easy to identify. To be sure, most of us are visual learners, and each of the bugs have distinguished physical features. So what's the good news? This topic is totally doable. The major obstacle will be inertia. Once you overcome inertia, you'll wish there were more questions on pulmonary fungal infections. Unfortunately, given the amount of material presented, I have broken this into 2 presentations. In this section, we'll cover a minimum amount of background information and the dimorphic organisms. So let's get started. We'll start by clarifying the nomenclature of the fungal organisms. Molds are multicellular organisms that grow in the form of thread-like filaments called hyphae. Yeast, on the other hand, grow as unicellular organisms. Dimorphic has characteristics of both mold and yeast, as we will discuss. To further clarify, the hyphae are described as either septated or not, and this becomes key language in distinguishing Aspergilla from Mucor. Hyphae reproduce at their tips by producing conidia or spores which cause disease by airborne transmission. Airborne implies we inhale these things, making the lungs the portal of entry for these infections. As for their sexuality, I don't like to get involved in their personal affairs, and neither does the NBME. Yeast are more straightforward. They reproduce by budding. Sometimes those buds fail to detach, and we're left with pseudohyphae in the case of Candida. We'll address Candida in part 2 of this presentation with the opportunistic yeasts. And finally, we have dimorphic fungi, namely Histoplasma, Blastomyces, and the Coccidioids. They exist as mold forms in the environment, but become yeast at body temperatures. I would encourage you to pay attention to any fungal question where the temperature is listed. If 25 degrees is noted, they are talking about mold forms. Be aware, this is a little trick they like to play. As for the term endemic, the intention here is to highlight that healthy or immunocompetent folks can develop clinical infection, as the organisms are largely contained by macrophages, just like tuberculosis. They can emerge or disseminate in the setting of immunodeficiency. However, immunodeficiency is not a requirement for becoming infected with these endemic organisms. I list some fun facts that may not be so much fun, but they're important to keep in mind, mostly as related to treatment. So fungi have cell membranes containing lipids, glycoproteins, and sterols. It is the sterols which should excite you, as these are primary treatment targets, namely ergosterol, which is the fungal version of cholesterol. Both amphotericin and the azoles affect ergosterol and thereby the cell membrane. Fungi also have cell walls with key constituents including chitin, mannan, and glucan. Be familiar with glucan. Its role in the cell wall is to provide structural scaffolding. As noted, humans don't possess cell walls, and bacterial cell walls are structurally different. The beta-glucan, therefore, becomes a target of therapy. The echinocandins, which inhibit glucan synthase, specifically target the glucans and thereby cell wall synthesis. Finally, it is good to know why the ecology of the organisms are so frequently mentioned, such as growing on pigeon, chicken, and bat droppings. It is because they eat this stuff. It is their source of nutrition. So if histoplasma is found in caves, and namely bat droppings on the floor of those caves, it is because they were hungry and find it tasty. To histo, it probably tastes like chicken, which is funny because histo also eats chicken droppings. And finally, a brief word on immune defense. Neutrophils phagocytize what and where they can. Sometimes hyphae are just too ginormous, and the neutrophils have to line up on the hyphae surface and fire away with lysozymes. That's a good plan, except when we are neutropenic. Then those delicate little hyphae become invasive bastards and wreak havoc, as we'll see with Aspergillus. T-cell mediated immunity and stimulation of macrophages is key to containing the organisms. Loss of T-cells, as in HIV infection, sets the stage for infection and/or dissemination, with principal examples being Cryptococcus and Pneumocystis. Whereas I mentioned immune deficiencies with the different organisms, I don't belabor the points as this is not typically a target of inquiry. Rather, the NBME informs you a patient is immunocompromised where necessary in the question stem. And just for completeness, humoral immunity is a small player in fungal infections. One less piece of information to study. Congratulations. So here's the game plan. We'll cover the endemic dimorphic fungi in this section, followed by opportunistic yeast and mold in part 2 of this presentation. It is very useful to start thinking in these categories purely because it gives some rhyme or reason to the topic. So let us start with the dimorphic fungi, beginning our discussion with histoplasma. Before even beginning our discussion of histoplasma, let me emphasize 2 points. 1. Histoplasma lives inside of macrophages, meaning when it disseminates, it will go wherever there are macrophages. That is, the bone marrow, spleen, liver, and lymph nodes. As such, histoplasmosis may be described as a disease of the reticuloendothelial system. Be prepared for the description of hepatosplenomegaly and lymphadenopathy with disseminated histoplasma questions. The other issue is the name, Histoplasma capsulatum. That's nonsense. The organism has no capsule. The name derives from the staining pattern, which appears to include a halo around the nucleus. This is a staining artifact that gives the organism a capsule-like appearance. The only fungus with a capsule is Cryptococcus, and be assured the NBME makes a very big deal about that capsule, as you will hear later. So when to suspect? Pay attention to geography and ecology. The geography of this organism is the Mississippi and Ohio River Valley. Be cautious as Blastomyces overlaps in this region. Be aware of the ecologic niche, chicken coops and caves. The caves are only relevant insofar as bats live in those caves. Bats crap in those caves, and histoplasma eats the damn stuff. Do also note the title for cave exploration, spelunking. They do use that term for purposes of deceit and tomfoolery. As for transmission, we inhale mold spores called microconidia that transform into yeast after inhalation. Although this seems irrelevant, and it is, I mention this to underscore what a dimorphic fungus does. Mold in the environment and yeast in our bodies. And the portal of entry is the lungs. Because it enters through the lungs, that is why these are presented as pulmonary fungal infections, even though the pulmonary component is pretty nonspecific. As for the microbiology, they do allude to the size as tiny. It's unlikely you'll have to select the correct size, but in the stem they'll use this description as part of the histoplasma language. The organism will be described as ovoid or pear-shaped. This is less helpful than residence inside the macrophage. But the macrophage doesn't kill the organism. It survives inside the macrophage, and that does set us up for the pathologic description. Caseating granulomas. The caseous component derives from the cell wall. I also compare and contrast here with Pneumocystis in the lower image, which might cause some confusion, but the key difference, Pneumocystis lives in the alveoli, not the macrophage. I also include a rupturing spherule releasing endospores as seen with Coccidioidomycosis. The endospores look like histo, but again not located in the macrophage, and histo does not have spherules. Once you're familiar with the other organisms and their characteristics, you'll have no trouble making these distinctions. As for pathology, we mentioned the highlights including residing within the macrophage and associated with caseating granulomas. And finally, for clinical presentation, as the lung is the portal of entry, the patient may experience a patchy pneumonia with associated adenopathy. This is totally nonspecific, but do be on guard for one of the clues to fungal and/or non-bacterial pneumonia, failure to improve with antibiotic. When they describe a patient with a chronic pneumonia that doesn't improve with antibiotics, be on the lookout for fungal pneumonia. Insofar as immunodeficiency, Both HIV and anti-TNF treatments are principal conditions the NBME will use to suggest dissemination of the organism. And two final points. Number one, all the dimorphic fungi can be associated with erythema nodosum. And number two, treatment will be listed to remind you about mechanisms of action. You'll almost never be asked to choose the best treatment for a pulmonary fungal infection. And that's it for histo. Let's move on to the next organism, Blastomyces dermatidides. We catch a nice break in the name dermatidides. That is, if they give you a frankly infected skin lesion, think about blastomycosis. Since this organism, like histoplasma, resides in the Mississippi River Valley, the morphologic features are going to be highly important to distinguish the two. This shouldn't be a problem, as the yeast form of blastomyces is unique and distinct from histoplasma. The classic description includes a single, broad-based bud and the double contour sign owing to the thick cell wall. This is a unique feature. Again, to compare and contrast, Cryptococcus is the only organism with a true capsule. It has a different staining characteristic with uneven, narrow base budding that will be discussed in the yeast section. So when to suspect? The geography is noted in the Mississippi River Valley and has no special ecology, just lives in the soil. The microbiology was already reviewed. Well, now we have some excitement. Note the pathology, pyogranuloma, that is PMNs and pus. This is the only fungal organism that causes suppurative lesions. Granulomas are infiltrated with PMNs. This is unique and one of the standouts with blastomycosis, skin or lung lesions with pyogranulomas. As for the presentation, otherwise nonspecific pulmonary findings. Dissemination outside of the lungs includes skin, bone, and GU tract, but the dermatitis component is the unique feature besides the morphology. And here is the summary. Skin with a suppurative, almost necrotic lesion. Pathology reveals a thick cell wall with visible nucleus, pyogranuloma, and a single broad-based bud. This is the face of blastomycosis. And just as a reminder, watch the temperature. Same patient, but if they ask about the organism at 25 degrees, there will be no budding. They are looking for mold and/or conidia. Pay attention to the temperature on a fungus question. It means something. So that's histo and blasto. One more dimorphic organism, the coccidioids. If I can pick a favorite fungus, this would be it. The geography is unique, being found in the Southwest, including Arizona and Southern California. The ecology is unique, growing in the desert soil. The mold form is unique, appearing as barrel-shaped arthroconidia that we'll review in a moment. But what makes this bug stand out in my mind is the infectivity. You just need to breathe in a single conidia and you're screwed. You have to admire a fungus that is so aggressive. As for the microbiology, a single arthroconidium grows into a spherule. The spherule develops septations, and from these endospores are derived. The spherule ruptures and releases the endospores. And here is why the disease is so destructive. Each endospore can create a new spherule. Those adorable little spherules destroy tissue both directly and resulting from the neutrophilic response. You want a pulmonary complication in this process? How about cavitary lesions? This is not a fun disease. Here are additional images emphasizing the barrel-shaped arthroconidia, the spherule filled with endospores, and a ruptured spherule releasing those endospores. Insofar as the pathology is concerned, I would highlight that neutrophils are active against the conidia and endospores, but not against the spherule. The spherule elicits a granulomatous response. As for the clinical condition, valley fever is described as a respiratory illness mimicking community-acquired pneumonia. Constitutional symptoms can last for weeks to months. That's not so good. The organism can affect the skin and/or elicit an inflammatory response in the form of erythema nodosum or multiforme. Joint symptoms are common, and as stated, cavities do develop. The infection can disseminate if immunocompromised, but this is broadly defined to include diabetes and pregnancy. This is a nasty player. Finally, be on guard for questions describing an increase in pulmonary infections, following a disruption in the desert soil, either by earthquakes or digging expeditions. These are clues to a coccidioidomycosis question. And those are the dimorphic bugs: Histoplasmosis, Blastomycosis, and Coccidioidomycosis. They each have unique features which should cause no confusion once you've decided to invest the time. So let's stop at this point and we'll resume the discussion in part 2 of this presentation, focusing on opportunistic yeast and molds. If you have any questions or concerns about any of the material presented so far, please email me at 12DaysinMarch. Thank you.